Hi everyone, my name is Robert Goldberg. I'm a pulmonary and critical care physician here at Mission Hospital as part of Mission Heritage Medical Group. I've been a physician here at Mission Hospital and as part of Mission Medical Group for 12 years. Today I'm going to discuss lung cancer as well as the importance of screening and various modalities of screening. As well, I am going to discuss a new technology that we've obtained at Mission Hospital in order to optimize the care of our patients in South Orange County. This year, we were fortunate enough to obtain a new technology that is helping us improve patient care and be able to care for patients in a way unique to Orange County. We are the first in Orange County, or one of the first in Orange County, as well as the first of Providence Healthcare to obtain this technology. So I'm proud to be able to present it, as well as some information about lung cancer. I cannot see the chat myself, but if there's any urgent questions, Chelsea, if you can let me know. Otherwise, I'll try to address any questions at the end of the presentation. We'll allow for people to speak and ask any questions if there's time allowing. So we're going to be talking about lung cancer. So lung cancer is the #1 cancer killer globally. In 2020, there were more than 228,000 new diagnoses of lung cancer in the US alone. So this is a very important topic. In 2020, there were 154,000 deaths secondary to lung cancer, over 83,000 in men and over 70,000 in women. And you can see that this dwarfs the next 3 cancers by far. In fact, lung cancer deaths are more than colorectal, pancreatic, and breast cancers combined. So it's an important topic to speak about. It's an important situation. And there are more cancers being diagnosed even in non-smokers. So all these years of preventing smoking cessation, advocating, educating the public on smoking cessation are helping, but it's not completely curing or reducing the number of lung cancers overall. Every 2.5 minutes, somebody will be diagnosed with lung cancer, and someone dies of lung cancer every 3.5 minutes. These are impressive numbers. And there were 135,000 lung cancer deaths in the last year. So what are the causes of lung cancer? Well, we've heard for greater than 30 to 40 years, more than that smoking causes lung cancer. There's been a huge public education campaign in order to reinforce this topic and to encourage the public to stop smoking. But even those who don't smoke can have risk factors for lung cancer. Radon, secondhand smoke, air pollution, and other factors in our environment that we can't avoid increased risk of lung cancer. Additionally, workplace exposures such as asbestos, chemicals, diesel exhaust can also increase the risk of lung cancer. Asbestos is known to cause a specific type of lung cancer called malignant mesothelioma, which is a cancer of the lining of the lungs. But that's not all. It increases your risk of all types of lung cancer. And then more recently, we're finding that DNA changes can lead to lung cancer or increase your risk of lung cancer. This is very important because in the last several years, we now have targeted therapies that target those DNA changes. So something that is new in lung cancer diagnosis and treatment is we actually take these cancer cells and do genetic analyses. And based on these genetic analyses, we can say which medications are more effective and better tolerated than our traditional approach to cancers, which is to give broad spectrum cytotoxic agents, meaning agents that kill fast-growing cells. Now we can actually target the cells, target the cancer cells, and get better outcomes. So signs and symptoms of cancer. Well, these are some common signs and symptoms that you'll see. A cough that doesn't go away and gets worse with time. Sometimes hoarseness can be a sign of lung cancer, chest pain, shortness of breath, or wheezing. People who have frequent lung infections or pneumonias or bronchitis or coughing up blood. But the most common symptom is nothing. People can have tumors that grow to impressive sizes with no symptoms at all. I had a patient early in my career who came to me with an abnormal chest X-ray. He had a softball-sized tumor in his lungs, and he had absolutely no symptoms. So it's scary that these tumors can grow and grow without any type of symptoms. Now, early diagnosis of lung cancer is vital. You can see that when we diagnose the patient at stage 1, and when we talk about stages of cancers in lung cancers, it's based on what's called the TMN staging system. T meaning tumor, N meaning lymph nodes, M meaning metastases. And each of these stages is based on how big the tumor is, what lymph nodes are involved, and are they found at any distant areas. Lung cancers usually will first go, how lung cancer grows is it starts off as a tumor or a lesion in the periphery of the lungs, and then it will grow to the lymph nodes that are next to that lung, and then to the central lymph nodes in the chest, and then it will metastasize to other parts of the body. The most common areas that it likes to metastasize to are the liver, the bone, and the brain. So when we diagnose at an early stage, meaning a localized lung cancer, the 5-year survival is quite impressive, 68 to 92%. This is also based on those genetic changes that we find in the tumors. If it has certain genetic profile, then certain chemotherapeutic agents or immunologic agents are better and more effective, so we have a better survival. Once we get to stage 4, that prognosis plummets to less than 10%. So early diagnosis is vital. Unfortunately, 40% of people, when we diagnose them, are already at a high stage, a stage 4, which is the highest stage. That means it's outside the chest, it's metastasized. So that prognosis is very poor. So we need better ways to be able to diagnose these patients at an earlier stage so that we can treat them more effectively. So there was the US National Lung Cancer Screening Trial, which found that annual screening of CTs can lower the death rate of those with lung cancer by 20% for certain individuals. So when in medicine, when we talk about screening tests, we need to evaluate them for various aspects. The US Preventive Task Force looks at screening tests, and first of all, it has to make sure that the screening test is effective. Can we actually find these tumors? Also, can we find these tumors at an early enough stage that it makes a difference? We look at malignancies like colon cancer. In medicine, we can do colonoscopies every 10 years because these tumors are usually very slow growing. So we can find them early enough in order to be able to treat them and potentially prevent them from metastasizing. On the other side, you have a fast growing tumor like pancreatic cancer. A majority of patients that get diagnosed are dead within 6 months. So we can't do a test early enough to be able to diagnose pancreatic cancer to successfully improve their survival. On the other side, we have to see how invasive the screening test is. Something like checking a PSA, which is a blood test, is fairly non-invasive versus colonoscopies, which most people who have had them will say that they're fairly invasive. So finding a proper screening test which allows us to be able to diagnose the lung cancer at an early enough stage in order to be able to make a difference, as well as that's not invasive. And also in medicine, the general powers that be need to make sure that it's cost effective. So they have done multiple studies looking for that screening test in lung cancer. And we've looked at chest X-rays. Unfortunately, with chest X-rays, by the time we can see lung cancer on a chest X-ray, it's already metastasized, so you don't have that ability to find it at an early enough stage. They looked at CT scans initially, and initially there was too much radiation associated with these CT scans, and they were too expensive. Well, now we have certain protocols that allow for low dose, meaning low radiation CT scans, and CT scan cost has come down to the point that it is effective in a certain population, being those 55 to 74 with at least 30 pack years of smoking, meaning they've smoked at least 1 pack per year for 30 years and have quit within the last 15 years or less. These patients have been shown to have a significant improvement in their outcome if we order yearly CT scans. And Mission Hospital currently has a program where we are obtaining yearly CT scans. And then on the other aspect, you have to have a physician or somebody who knows what to do with the information and what the next steps are. So we have a whole program set up at Mission Hospital where we are performing these yearly CT scans, and then we have a tracking program to make sure that we monitor these patients with those positive CT scans. When we find lesions, they're usually nodules. They can be found anywhere in your lungs, even in hard to reach areas, and the vast majority of nodules are not malignant. One of the common referrals I get is patients with abnormal CT scans. They have a nodule. The primary care physician or other physician found it because the CT scan was done for some other reason. Or, for instance, people are frequently getting CT coronary angiograms, meaning rather than doing an angiogram through the leg for screening, individuals will get a CT scan that will be able to look at the coronary arteries, and we'll find lung nodules. These patients will be referred for these nodules. Currently, there is a recommendation called the Fleischner criteria, which is what we use because as more and more people are getting CT scans and the CT scans are getting better and better, more higher resolution, we're finding more of these nodules. So the Fleischner criteria gives some guidance of what to do in the next steps. And this is based on the size of the nodule, characteristics of the nodule, how many nodules are found, as well as what the individual's risk factor is. And this gives guidance of whether we need to do a CT scan in 3 months, 6 months, 9 months, a year, or no CT scan at all. And then in the high risk individuals with large tumors or various characteristics, sometimes the recommendation is to biopsy or obtain further imaging such as a PET scan. So we take these Fleischner criteria and use them in order to be able to decide what are the next steps for addressing these lung nodules. So there are several different ways to biopsy these lung nodules, both the ones that are near the periphery, meaning the outside lung, as well as more centrally. The oldest, most traditional way to biopsy would be surgery. This was first started in 1861. There's a procedure called a wedge resection where a surgeon will go into the chest and remove a piece of the lung. Very invasive, as you can imagine, and it's not curative for a wedge resection normally. Normally, when we find a tumor, we have to take the entire lobe of the lung in order for it to be the most effective. There are new studies where they're looking at taking smaller parts of the lung, doing what's called partial lobectomies, and making sure, because when we find the tumor, it's not just those cells that are in the lungs. We're also worried about cells that are moving towards the lymph nodes more centrally located. In the 1940s, a new procedure was called transthoracic needle aspiration. What that is that a surgeon will take a needle from the outside of the chest and go through the chest wall under usually CT guidance in order to obtain needle biopsies of these tumors. Less invasive than surgery, but still invasive, and as you'll see later in the presentation, does have some risk factors. In the 1960s, 1968, bronchoscopy was developed. This was first developed in Japan, and it's where the initial was utilizing fiber optics in order to take a little tube, go into the nose or mouth, and go into the lungs. Now we use digital bronchoscopy, flexible bronchoscopy. There's also something called rigid bronchoscopy, which is a little more invasive, but it's less invasive. But our issue with bronchoscopy is that with traditional bronchoscopy, we can only obtain the first generations of airways. How the airways start is they start off as the trachea, which is the main airway, and then splits off into the right and left main stem airways. And then from there, it splits off into the right upper lobe, the right middle lobe, and lower lobe. And within those, there's exponential increase in the number of airways. And on the left, there's the left upper lobe, the lingula, which is like the right middle lobe, and then the left lower lobe. And again, the airways split off and increase in number exponentially. So normally we can only go into the main subsegmental airways, meaning the upper lobe, middle lobe, and lower lobe airways, and maybe 1 or 2 generations past that. So then in 2003, there was a new type of technology called virtual navigation, which utilizes some type of generator, some type of guidance based on the CT to go further into the lung. And I'll discuss this and show some videos of this later. But it still wasn't the best technology, as you'll see in a video later. Still, we didn't have quite the fidelity to be able to find these lesions and the control to be able to get to the lesions. So more recently in 2018, a new technology was approved called the Monarch Bronchoscopy, which is utilizing robotics and virtual navigation together in order to be able to obtain or approach these lesions further in the lung. We can even go all the way to the periphery, which was unheard of previously, going all the way to the edge of the lung to be able to get to these lesions. And there's 2 companies out there, but we went with the most advanced, what we feel was the best technology, which was the Monarch robot. So a little information, let me show you this video about Monarch to introduce it. I'm sorry, whoops.
Physicians strive to diagnose lung cancer early in order to give their patients the best chance at survival. Unfortunately, with current technology, only 15% of cases are diagnosed at the earliest stage. Roughly 1/3 of patients leave without a diagnosis and must wait to see if the lesion grows. Bronchoscopes have largely remained unchanged over the last 60 years. Physicians are challenged by the limited reach, precision, and control inherent with the physical design. Introducing the Monarch Platform. The Monarch Platform was designed to transform endoscopy by overcoming current challenges and extending physicians' capabilities. Expanding control through a novel and instinctive interface, users can now navigate farther into the periphery of the lung with greater access and precision through a leap forward in endoscopic design, all while maintaining direct vision during the intervention. The Monarch Platform is designed to extend across endoscopic specialties. We are currently developing solutions for multiple specialties. At Auris, we create platforms that enhance physician capabilities and improve patient outcomes with safer procedures. Together, we can fight lung cancer and change patients' lives. Never lose sight of what's most important.
So never lose sight, that's the key, is being able to get to those lesions and see them and do our procedures, do our biopsies with constant vision. It improves the safety as well as our success at obtaining accurate biopsies, diagnostic biopsies. So why did we acquire Monarch? Why did Providence Mission Hospital obtain Monarch? Is, as you can see, again, like we spoke, lung cancer is a huge issue in the US, 163,000 annual cancer deaths. And as we discussed earlier, the later the stage, the worse the survival. If you can diagnose it early when it's localized, the death rate is about approximately 15%. As it becomes regional, meaning getting into the lymph nodes, it goes up to 22. Once it's distant, the survival plummets. And unfortunately, the survival plummets down to 4%. Meanwhile, the percent of patients that we're diagnosing with distant metastases is 57% versus those with regional at 22 and 15% at local. So our traditional biopsy that we spoke about, transthoracic needle aspiration, it has a high yield, 90%. Unfortunately, it also has a high complication rate of 25%. And of those, 4 to 8% will need hospitalization or a chest tube placement, and you'll get up to 1% hemorrhage. So high yield, but high risk, relatively, versus the flexible bronchoscope with the advanced technology that we'll talk about, which is the previous navigational bronchoscopy. The yield was much lower at 44 to 72% with a lower pneumothorax. So if we could find some way to get the high yield with the low risk, that would be best. And with Monarch, we were able to find a technology that provided this. Monarch with what's called Rebus, which is a small ultrasound probe that we will put up against the wall of the airways to make sure that we're where the tumor is, as well as using the localization, the Monarch assisted navigation provides us with up to a 95% diagnostic yield. And there's our low risk, 4.3% risk of pneumothorax, only 2% risk of requiring hospitalization or chest tube with minimal hemorrhage. And if we can find lesions that have what's called the bronchus sign, meaning we can see the lesion around the airway, meaning there's an airway going through the lesion, our yield increases compared to a non-bronchus, meaning the lesion is outside of the airway. The other aspect that makes this technology and Monarch so important is that Monarch is part of Auris, which is part of Johnson & Johnson. And Johnson & Johnson has what's called the Lung Cancer Initiative, meaning they have vertical integration of both diagnostic as well as treatment options or research into these options. So right now, we are right here in the middle. When we find an early lung cancer, hopefully, we are able to locate and diagnose it with the Monarch robot. Future potential is that hopefully we can find before those lesions become cancer, when the tumors are just starting to change, when they're just starting to get those genetic abnormalities, maybe we can find these tumors earlier in what currently we have what's called ground glass opacities, which are felt to be a early stage of tumor or pre-cancer stage. If we can and these are notoriously hard to diagnose with all our current technologies, when we find them or can find them with Monarch, hopefully we can treat them and maybe even inject some type of therapeutic agent to prevent them from advancing and becoming lung cancers. At some point in the future, Johnson & Johnson is working on being able to treat these cancers without having to do surgery or chemotherapy. Maybe we can get to these lesions, diagnose them, and then directly inject chemotherapeutic agents or energy into these tumors. These are all under investigation, as I'll show you later. And then something that we're doing now at Mission Hospital is when a surgeon is planning to take out a cancerous lesion, he needs to be able to feel the lesion. Well, now we have these more advanced options such as the Da Vinci robot, which Mission Hospital has several of these, that allow surgeons to do the procedure with smaller holes, better recovery. The problem is the surgeons don't have the feel that they normally would with their fingertips. So we need some other way to aid the surgeons in order to be able to find these tumors. And so one procedure that we've been doing at Mission Hospital is that we will approach these tumors with the Monarch robot and then inject dye in order to mark the tumor, and then immediately take the patient into the next operating room, and the surgeon will cut out that piece of lung. Therefore, he's able to cut out a smaller piece of lung, take out less lung with a better recovery. So here's a sample. You saw this, what the bronchoscopes are like today. We can get to the main airways, we can see the airways, but we really can't get to those more distal airways, and we don't have the control that we would want. And as I discussed, This was the previous navigational bronchoscopy. It would utilize a field generator and this little probe, which the field generator was trying to help guide. But you're trying to find this green ball, this target, and it just doesn't have the fidelity. And we aren't able to get distally into the airways to be able to see what's down there. You're sort of blindly trying to catch that ball, which could be very, very frustrating. And when you think you're at the lesion, we use a live X-ray to be able to see where we are. The lesion, we're not anywhere close to where the lesion, where we thought we were right here, when we finally pass the tools, we find out we're in a completely different airway. We think we're there, but in actuality, we're in a completely different part of the lung. So the yield wasn't as great as what we can achieve with the Monarch robot. So this is what the Monarch robot looks like when we bring it out. We use a specialized CT in order to find the lesion, and then we plan out how we're going to get to the lesion. The software helps us find those airways, and then we use this controller, which is really based on an Xbox controller, to be able to control that bronchoscope all the way to that lesion. And then again, we use something like radial EBUS, the radial ultrasound, in order to make sure that we're right next to that lesion. And it really is like using an Xbox controller. I joke around that the reason why I wanted to get this technology was so that I could beat my kids at Xbox. But it really is based on that technology to control these bronchoscopes, that then we can find these lesions, know that we're close to them, get biopsies, and then what we do is we send those biopsies immediately to the pathologist, who will tell us, yes, you are in the lesion. And so what happens is the patient is intubated by the anesthesiologist. We then insert the bronchoscope into the airway, and then we control that bronchoscope into those distal lesions utilizing the technology. There's a double sheath design, which is unique. The first sheath allows us to get some type of rigidity, so we can use the second sheath to get distally in the airways. We wouldn't have that ability because the bronchoscope was too flexible previous. So having that double sheath design makes a huge difference in allowing us to get to those distal airways, and then having the vision to be able to see where the airways are, because we're basing our navigation on a static picture. We ask the patient to take a deep breath, they do a CT scan. Well, in real life, patients can't hold their breath for 10 to 15 minutes while we're doing the procedure. There is some movement. So being able to see where we are, utilizing technologies like radial ultrasound in order to make sure we are in that lesion, do significantly improve our yield so that we can get those biopsies. So the Monarch robot right now, today, as we spoke about, its main technology is to diagnose lung cancers. In the future, the hope is that we'll be able to locally deliver chemotherapeutic agents, immunologic agents, or even local energy to basically irradiate these tumors and hopefully treat them locally. There's even studies ongoing. There's a major study at the University of Vermont in which they are directly delivering drugs to these tumors when they are diagnosed. This is the Monarch Flex trial, and then the Monarch drug delivery trial. So again, just some pictures. The Monarch robot gives us this ability to make turns to approach areas of the lung that were never able to be approached before. We would never have been able to make a U-turn like we're seeing in this fluoroscopic picture, live X-ray picture, with a traditional bronchoscope. So we're able to approach lesions that we never were able to before. And then we utilize advanced technologies such as fluoroscopy, live X-ray to make sure that we're in those areas, as well as the radial EBUS as I discussed. So in this we can see we utilize technology, the new platform, the scope and sheath pairing allows the control that we needed. It allows the reach, in order to get to those lesions that we never could have. And then the other aspect is with the older technologies, bronchoscopists would have to sit there and hold the bronchoscope and stay still, make sure that they're not moving so that they don't go into a different airway. With this technology, we can pause the controller and just leave the bronchoscope in the area, do our biopsies, get the information from the pathologist, and then take further biopsies if needed, or move to another location if we're not in the right location. So having that ability to pause the bronchoscope and leave it without me, the bronchoscopist, staying still for that extended period of time improves our overall experience and our yield and the experience and success for the patient. So how this is done, what makes the big difference is we use electromagnetic forces in order to know where the bronchoscope is in the airway. The Monarch platform utilizes optic pattern recognition based on the CT scan in order to know which airway. We basically have a GPS. We have a little GPS signal that's telling us, okay, go into this airway, go into that airway, in order to get as close to the lesion as possible. And then again, the robot helps us know where we are and control the bronchoscope so that we have the control that we wouldn't normally have previously. And with that, those technologies, we're able to approach these lesions, know where we are, and obtain those successful biopsies, and hopefully eventually be able to treat them locally as well. We have various different screens that we use in order to know where we are in the lung, how far away we are from the tumor, tells us our distance from the tumor, and whether we're on the right guidance going into the right airways. And with this, the combination of all these aspects, it has been proven, this is through CHEST in 2018, that there was a 97% accuracy in obtaining diagnostic biopsies. So why we chose Monarch? First of all, we wanted to be able to have that reach. This is a traditional bronchoscope. This is as far as we could get, just to the main airways. And we could push tools out, but that was awfully risky to blindly push tools out to the periphery. Now, with the Monarch platform, we're able to get all the way to the periphery, all the way to lesions we never would have thought that we could get to before. And to be able to know where we are in the lung was a huge technological advancement for us as bronchoscopists, as pulmonologists trying to diagnose these tumors. Vision, being able, how it works is we've got this working channel, we've got the fiber optic camera, and then 2 light sources. So we're able to see where we are throughout the tumor. In this video, somebody was trying to biopsy and they're just sliding past. They're not actually getting the tumor. Without having that vision, we never would have known that we were just sliding past and getting what's called air balls, meaning we weren't getting true tissue. So now we can actually watch the needle go into the airway and know that we are where we are supposed to be. And then the control, in this they were trying to put the needle in the eye of the eagle on the back of a dollar bill. You can see that they can the bronchoscopist can make those micro movements in order to get the needle in that exact target where it needs to be. One thing that I've done already a couple times is I will put a needle in a lesion and then find out that, yes, I'm in the tumor. So then I'll use a larger tool called forceps and be able to put, the forceps are a blunt nose, they're like little graspers, and I'm able to have the control to put my forceps right in the hole produced by the needle. So a 22 gauge needle, which is smaller than an IV that a patient would normally have placed, I'm able to put these forceps directly into that hole and obtain larger biopsies that allow for more studies, those genetic studies that are necessary in order to be able to find out what that genetic profile of the tumor is. So in summary, lung cancer is a huge issue with very high mortality, especially when it's diagnosed at a late stage. And as you can see from earlier in the slides, Unfortunately, currently we are finding it at late stages. So how this is being addressed is with screening CTs in those individuals that have those characteristics, the years of smoking, their age, and how long ago they quit. And that improves their risk by up to 20%. Number two is being able to have the technology to approach these lesions and be able to diagnose them, have the control so that we can maintain in the airway we want to be able to biopsy where we want and use advanced tools such as biopsy forceps. And the eventual goal is to be able to directly treat these tumors with either directly injected chemotherapeutic agents, directly injected immunologic agents, or therapies such as radiation, or even what's called cryotherapy, where we freeze the tumors, which will kill the cells and therefore treat the lung cancers. So Monarch platform gave us that control, that ability to reach these lesions, and that's why we chose it. And we're hoping that with this, we will be able to improve the care of patients across the board at Mission Hospital. And it's part of our lung cancer initiative here at Mission Hospital. We have what's called the Leonard Cancer Institute, in which we are focusing on certain cancers in general, but especially certain cancers such as colon, breast, and lung cancer is one of those initiatives. And this Monarch platform is helping us improve the care for those individuals at Mission Hospital. Now, if we have any questions.
Hi, my name is Ken. My question is the smoking portion of the impact for in the required age group, is the smoking criteria also necessary in order to be able to do the low dose CT?
Yes. So this is based on studies, many of them at Sloan Kettering in New York, in which they looked at various populations to see in which population does obtaining the yearly low-dose CT make a difference in their outcome. And what was seen was smokers, people who have smoked at least 30 packs per year. And actually, as of last month, the U.S. Preventive Task Force is the nationwide organization which makes the recommendations for screening tests. The U.S. Preventive Task Force previously recommended that those individuals with 30 pack years of smoking, meaning 1 pack per day for 30 years, would obtain the low-dose CT. Currently, as of the last 1 to 2 months, they lowered that threshold to 20 pack years of smoking. So yes, based on the U.S. Preventive Task Force recommendations, smoking history is necessary. That is just because the risk of cancer in non-smokers is lower. It's still there, but it is lower. And so the risk of the radiation from those yearly CTs compared to the benefit of obtaining the CTs is lower in those individuals without the smoking history.
Thank you.
The other aspect that I would say is if a nodule is found incidentally, then we don't need the smoking history in order to obtain serial CTs. Then we fall back on that Fleischner criteria, the criteria which looks at the size of the lesions, the number of lesions, what their characteristic is. Are they solid? Are they what's called spiculated, meaning when you look at a lesion, if it's nice and round, then usually that's a better sign. But if it has what's called spiculations, meaning it looks like it's trying to grow out, that's more concern for it being a malignancy. And then the risk of the individual. So if you have risk factors such as an occupational exposure, or you live in a high pollution area, then we would use the Fleischner criteria in order to make recommendations about what future CTs should be obtained.
Thank you.
Any other questions? And then were there any questions in the chat? I don't have the ability to look at the chat, unfortunately.
No, there was no questions in the chat box. Thank you so much, Dr. Goldberg, for taking the time to give us this informative webinar. Is there any other questions that we could answer?
Well, in that case, thank you everyone for joining the web chat. It was recorded, so if anybody would like to see it at a later point, Chelsea, where would they be able to see it?
I will put my email in the chat box. They're more welcome to reach out to me, and I'll be more than happy to send it to them.
Okay. Well, if there's no other questions, I guess we're ending a little bit early, but thank you very much for joining me for this webinar.
Thank you, everyone. One last thing maybe I could share with everybody is that we do have other classes that are available on our website. Please take a look at it or let us know what subjects you guys are looking for, and we'll be more than happy to arrange those for you. Thank you so much for taking the time to join our webinar, and have a great evening.